Hello and welcome to this episode of The Doctor is In. I'm Dr. Aniruddha Agarwal, a vitreoretina surgeon and uveitis specialist at Cleveland Clinic, Abu Dhabi. Joining me today is my esteemed colleague and good friend, Dr. Mohamed Sayed.
Thank you so much, Dr. Agarwal. Hello, my name is Dr. Mohamed Sayed. I'm a consultant ophthalmologist in the Ophthalmology Department of the Integrated Surgical Institute of Cleveland Clinic, Abu Dhabi. Thank you for having me today.
At Cleveland Clinic, Abu Dhabi, we are proud to be a part of this campaign. In terms of eye related conditions, there are two important conditions that we would like to focus on in our conversation today. One of them is glaucoma, and the other is diabetic retinopathy. As you know, Dr. Saeed, both of these conditions are highly prevalent in the world as well as in UAE. So let's begin by talking about glaucoma. Glaucoma is a silent killer of vision. So tell us something, a brief introduction of what is glaucoma, what is blue water that we usually refer to in our layman language.
Thank you so much. First of all, I think that the choice of topic cannot be more appropriate at this time because we live in a world that is aging, and both of these conditions are diseases of old age, even though they can happen in across age groups, different age groups, from like children to the elderly. But in fact, they are diseases of old age. And with the advancement in healthcare, we are seeing the population getting older and older. And these conditions, we are seeing them way more often than we used to see them many years ago. So, to answer your question, Dr. Agarwal, glaucoma is a disease that affects the optic nerve. And it is related to the pressure inside the eye. The optic nerve cannot withstand the pressure inside the eye. Whether that pressure is actually elevated above the normal range for the population, which is the more common form of glaucoma, or even if the pressure is still within normal limits, but the optic nerve for that particular patient cannot really withstand the normal pressure inside the eye. So it is a pressure sensitive optic neuropathy. And there are two problems with glaucoma. Number one is that initially, in the early stages of the disease, it doesn't really have any symptoms. So the patients feel that they are completely fine, they are seeing well, because their central vision is preserved until the very last stages of the disease. So this is the number one problem. Number two problem is that it's irreversible. So whenever we diagnose glaucoma, we can actually stop or slow down its progression, but we cannot reverse the damage that had already been done. And it's funny you actually mentioned blue water because in Arabic we call glaucoma al-ma al-azraq. But I want to be very careful here because like depending on where you come from in the Middle East, like you can have different designations for different diseases. So for example, in the Gulf area we call cataract ma abyad or white water, and we call glaucoma al-ma al-azraq or blue water. In other countries, they call the cataract blue water, and they call glaucoma black water. So it's just like to avoid confusion, I always tell my patients, let's just call it glaucoma or cataract rather than use this confusing watercolor nomenclature.
This is, I think, a very excellent introduction to what is glaucoma. But there are certain areas where still we feel as clinicians and even as patients a bit of a confusion when it comes to who is at risk of developing glaucoma. And we often face this challenge when we see patients in the clinic and they come and tell us one of our relatives, a family member was diagnosed with glaucoma, is potentially on eye drops. So, how do you counsel patients and identify patients who are at risk of glaucoma and those who really need treatment?
Sure. So there are certain subgroups of the population that are at high risk of developing glaucoma. Number one, um, uh, old age. So glaucoma, like we said, is a disease of old age. And therefore, any person, when they turn the age of 40, should really have a baseline eye exam. And that baseline eye exam will include measurement of the pressure inside the eye and will include the evaluation of one's optic nerve. And if all is healthy, then like depending on whether there is comorbidities or other like diseases that the patient has or not, like we take it from there and recommend like follow up at certain intervals. In these particular cases, where we have family history, or we have high degrees of refractive error, we should actually be more careful. I always tell my patients that actually glaucoma is a genetic hereditary disease. And therefore, if you have a first degree relative with glaucoma, it is highly recommended that you seek help from a glaucoma specialist or at least a comprehensive ophthalmologist who can, like look at your optic nerve, measure your eye pressure, ensure that all is okay. Or if there are if there is any suspicion that actually glaucoma has actually begun, then we start treatment. Can I actually ask you a question now? So, you see a lot of patients with diabetic retinopathy, and diabetic retinopathy is very prevalent in the UAE in particular, in Arab countries in general. When I was in the US, for example, I don't remember seeing as many patients with diabetic retinopathy as we do see here. So it's a very prevalent condition, and is there an age where patients should be screened initially for diabetic retinopathy if they have a history of diabetes or a family history of diabetes?
I think we are discussing a very important point here, which is screening of the disease and at what age and what population should be screened. And I really appreciate your pointing out how we should screen for glaucoma and the fact that diabetic retinopathy is so prevalent in our region, in the entire Gulf region, and in general, worldwide, we are seeing a lot of patients with very severe diabetic retinopathy. There are definite guidelines that have been published in terms of screening for diabetic retinopathy. Like you said, for glaucoma, there is no age where diabetic retinopathy cannot happen. Usually, it does not happen in very young age, maybe in the first decade of life. But we have patients who have type 1 diabetes, and they can present very early in their life with changes of diabetic retinopathy. But usually, since they are young, they are often very aware of their surroundings and they present early if there is a visual loss. And so, the general recommendation for type 1 diabetics, when the onset of the disease is very early, is to have a screening at least 5 years from within the diagnosis of the type 1 diabetes. However, if the patient has diabetes detection later on in life, you should get a screening done as soon as possible. And what does the screening entail? It basically entails an examination in the clinic, preferably with a full dilated examination. That is, we put some drops in the eye, we dilate the pupil, and check the whole retina. Sometimes we need to do additional scans, such as photography or OCT, and that's the only way we can diagnose diabetic retinopathy. Now, let me take you back a bit. When you talk about genetics, and there is some genetic linkage when it comes to diabetic retinopathy as well. There are certain genotypes and genetic profiles which make the person more prone to developing retinopathy. Do you think that glaucoma is in general a genetic disease, or do you see patients outside of the spectrum of genetic involvement?
That's an excellent question. In fact, a lot of the subtypes of glaucoma do have genetic predisposition and are hereditary, but there are other types of glaucoma that do not necessarily have a genetic inheritance pattern. For example, trauma. So if somebody sustains a trauma to the eye, they are susceptible to developing a range of ocular conditions, including cataract, including a retinal tear, including something that we call angle recession. And angle recession can cause glaucoma. And like also the patient might develop bleeding inside the eye that we call hyphema if it affects the front part of the eye, which also can raise the eye pressure and cause glaucoma. So, to recap, while the majority of types of glaucoma do have genetic factors involved, there are other types of glaucoma that are not necessarily genetically inherited.
So let me ask you this. Thank you for pointing out the various factors related to the screening of glaucoma. Now, we all know that almost all of us are into AI and we use various programs and software such as ChatGPT.
Absolutely.
So, when it comes to artificial intelligence, do you think that AI has already been integrated into glaucoma care?
Thank you so much. This is an excellent question. In fact, in this day and age, we do not treat all patients alike. We do what we call personalized medicine or precision medicine. That is really every intervention is specific to that particular patient. And the advances of artificial intelligence technologies in medicine and in ophthalmology in particular have made this possible. And we are already seeing a lot of AI being integrated in ocular disease detection. For glaucoma, for example, we rely on monitoring the patient's optic nerve structure as well as the function of the optic nerve, which is the visual field, right? And we determine whether it has gotten worse or it has been stable. But once it has gotten worse, there is nothing much that we can do except maybe try to lower the pressure and maintain the level of structure and function that we have after that it had already gotten worse. So what AI is doing right now is that it's identifying novel features in the tests that we do regularly, which is the optical coherence tomography imaging for the optic nerve and the visual field. We are now able to identify things that were not looked at in the past. And these high-risk features that we are able to identify thanks to AI can now help us identify the higher risk groups that need more more timely management and maybe some more aggressive form of treatment, if you want to say. So we are seeing this right now. We are actually part of all the research that's going on to integrate AI in eye care and in particular in glaucoma. So in parallel, we're also seeing advancement in how we undergo research in ocular disease. For example, the highest level of evidence that we always had was randomized controlled trials. And it still is the highest level of evidence that we have, but it's not without limitations. The advancement, the huge advancement in AI and in big data is allowing us now to actually use millions and millions of data points that we call big data from millions of patients, from thousands of centers around the world. That we have all this pooled data that we can actually extract what we need from, and we are finding that disease associations that existed in the past are no longer, considered valid, and so on and so forth. So AI is actually shaping the way we practice medicine, and particularly ophthalmology right now. And let me take this opportunity to actually ask you about diabetic retinopathy. Is there a role for AI in diabetic retinopathy screening and management?
So this is really an area of my interest, and to the audience, I really encourage you to leverage this opportunity that we at Cleveland Clinic are pursuing AI into eye care. And retinal disease is actually one of the major factors where AI can change the shape of the entire ophthalmology scenario and eye care. making it accessible and available to all of us, even remotely. And in terms of diabetic retinopathy, it's very easy to imagine a future where you can have a picture taken in a kiosk and have it screened by an AI based tool, and that can actually tell you the risk of retinopathy. It can also point out various other conditions apart from diabetic retinopathy. It can just tell you the risk of systemic disease, for instance, the risk of development of heart related issues, neurodegeneration, risk of stroke. The list is endless. But when it comes to diabetic retinopathy, the most critical point where AI really helps us is to pick cases or patients who have very severe vision threatening disease. As you know, some patients present to us without visual symptoms. They are 6 by 6 or 20/20 vision. And they may have only very few symptoms, such as a floater here and there, but no major symptom which is affecting their vision. But when we examine them in the clinic, in a fully dilated pupil examination with photographs and scans of the retina, we realize that they have a very serious underlying disease that needs urgent treatment and intervention.
Absolutely.
And these are the patients really where we at Cleveland Clinic would like to intervene, identify such patients, and help them.
Absolutely. So let me go back to the basics and ask you, what is the importance of having one's diabetes controlled to prevent the progression, the development and the progression of diabetic retinopathy? Is it important that we control the diabetes, or it's just going to happen no matter what we do?
So there are two aspects to this question. There is no doubt that systemic control of diabetes and bringing down your accumulated blood glucose level, which is we call it as the HbA1c levels, to below an acceptable level. The general acceptance is less than 7.
Yes.
And this metabolic control is extremely important in deciding your future in terms of the eye health, but not just eye. It also translates into the kidney and various end organs of the body. So a very strict control of diabetes is essential to delay the occurrence of diabetic retinopathy, nephropathy, and several other end organ damages that can be associated with diabetes. And it's very well established that high diabetes levels are strongly associated with cardiac disease, with stroke, and so many other metabolic diseases, which we see every day. The other aspect is we see patients coming to us and they say that they have a very good control of diabetes for the last so many years, but still they have progression of diabetic retinopathy. And this is a very important aspect for us to understand, that if you start with diabetes and if you have a duration of more than 15, 20, 25 years of diabetes, your risk of having diabetic retinopathy does go high, even though you have very good control of the disease. This is a long-standing damage which affects the blood vessels of the retina and making them leaky, fragile, resulting in downline complications such as bleeding, structural damage, detachments of the retina. And so they can be independent of the level of diabetes. And that's why if you have diabetes, it's really critical for you to have an eye exam. And we stress this at all levels, including
Absolutely.
patients who come at an endocrinology clinic as well.
So since the two of us are here today, you're an expert in retinal surgery and I specialize in glaucoma, can diabetic retinopathy result in glaucoma?
And this is a very difficult topic when it happens, because these patients represent a pool of patients where there is a severe threat to vision and we have limited options. But if timely intervention is done, these patients can really regain a significant amount of vision and go back to living a normal life. So when does high pressure and diabetic retinopathy go hand in hand? And this usually happens if either of them is not controlled very well. And most commonly, if the diabetic retinopathy is allowed to progress, patients can develop a situation where they have abnormal new blood vessels in the retina. And these blood vessels are fragile and leaky, as I mentioned before, and they can bleed. They can bleed or they can leak fluid, and they can add to the pressure of the eye. And when this happens, it's important for us as clinicians to recognize that the patient has a critical condition which requires an aggressive treatment. You need to treat not only the pressure, and for that we have your expertise, but we also need to treat the diabetic retinopathy. And that may require lasers, it may require injections, or it may even require surgical interventions depending on the situation. So we need to work very closely with each other, as you know, to manage these patients. They represent a special set of cohort that we see.
Thank you. And in fact, I was part of this research project that concluded that the main way of avoiding glaucoma surgery in a patient with advanced proliferative diabetic retinopathy is to actually laser the patient. So when we see these complex patients together, I always tell my patient, you go to Dr. Agarwal, you get the laser done, and then we'll see whether we'll need a glaucoma intervention or not. That takes me actually to another question. So when we talk about treatment of diabetic retinopathy, every day we hear about a new injection, a new molecule that had been developed to treat diabetic retinopathy. And for somebody who's not a retina specialist like myself, it's a little bit overwhelming with there's different protocols. There is so many molecules to choose from, so many doses and regimens. So how do you personalize? How do you choose? How do you personalize your treatment plan?
Certainly, there are several agents, medications that are available that we can use and inject. And this is a whole spectrum of medications that we currently have. We are very fortunate to have a number of these treatments available. When it comes to specific regimens and protocols that we follow, there are differences. As you said earlier, personalized medicine and precision medicine is really the way to go. So we use injections on a case-to-case basis. And what we like to do is choose among the several injections that we have. These are all under the category of what we call anti-VEGF injections or anti-vascular endothelial growth factor injections. And now we are fortunate to have agents that are long lasting. They last for several months. And so the interval and the treatment burden has significantly gone down for patients. Now, when it comes to choosing an agent, it really depends on the findings that the physician sees in the eye, the patient factors such as the thickness of the retina, for example, the other changes of diabetic retinopathy in the retina. So it's very personalized. And we look at several features which we call biomarkers on the OCT. And this is really an emphasis that we pay on in the clinical visit. And we decide the agent and the protocol. Certain patients require more frequent injections. Certain patients require less injections just to maintain their course of the disease.
Okay, interesting. So I cannot really end this podcast without asking this question, which might be a little bit irrelevant to the topics that we're discussing. But I get asked this question all the time in the clinic, and I would love to know what you think about it. A lot of patients right now, it might actually be relevant because it's related to diabetes. They are using the new diabetes slash obesity injectable medications for weight loss. And I believe there has been some reports recently that link some of these medicines to visual loss. And a lot of patients come to me and ask me if they should actually stop using the medication. What would you tell your patients?
I think this is a very important question and really a burning issue right now. We know that several patients are either administered the weight loss or anti-obesity medications as a part of the diabetes protocol for management or standalone for weight loss. And there have been definite reports of associations of what we call as anterior ischemic optic neuropathy, which is basically lack of blood supply to the optic nerve. And this can cause irreversible visual loss. So before you are put on any of these medications, my general advice would be to see an ophthalmologist if you are at risk. And this risk will be assessed by your physician, endocrinologist, who is prescribing you these medications. And I'm very happy to say that the Department of Health Abu Dhabi has taken very strict cognizance of this issue. And we want to prevent, the use of medications where it can lead to undesirable side effects. So at the end of our podcast, I think both Dr. Saeed and myself would like to tell you to please take care of your eyes, seek early diagnosis and management of your condition for you and your family. Thank you very much.
Thank you very much for having me today. And my message at the end of this podcast is please be very compliant with your medications and with your follow-up schedule. Missing follow-ups and not being compliant with medications can actually lead to very undesirable effects. Thank you so much, and I wish you all a healthy life without glaucoma and without diabetic retinopathy.